Today, we will be discussing the 2-point discrimination test, as there are 2 different tests and 2 different tools that we can use for this measurement. So these tests assess the ability to discriminate between 2 static points when placed on the skin at the same time. It tests receptor density, mapping improvement after nerve repair, and the ability of the hand to complete fine motor tasks. It is a non-standardized assessment used to test sensation, and age range starts from about 2 throughout the lifespan. The population that this test is used for can be hemiplegia, stroke, tetraplegia, peripheral nerve injury, anything that really is affecting those peripheral nerves in the fingers or hand. The length of administration could start around about a minute. The administration of this test is fairly short if one trial is being completed, though there are variations in which the test was administered 2 to 3 times with a 1-minute lapse in between that I found in some sources. The inter-rater reliability as well as the intra-rater reliability and test retest are all good, and there was no official reports of validity found, though some sources state that both the moving and static 2-point discrimination tests are valid measurements of functional sensibility in the hand, and that these tests are good in comparison to some other tests that can be done to assess sensation. When administering the static 2-point discrimination test, we are going to use a device such as the JMAR discriminator or an aesthesiometer with blunt testing ends. We test only the tip of every digit, as this is where the receptors are most dense, and the client must have their eyes closed. We begin with whichever tool we're using at a distance of 5 millimeters apart. We'll randomly test a couple of points on both the radial and ulnar sides of each finger 10 times. These points must be parallel to the longitudinal axis of the finger to avoid stimulating other nerves. We apply just enough pressure so that the skin blanches and then lift off, and they will report back to us. This will be discussed in the following video one more time. So I am going to be administering the static 2-point discrimination test with the JMAR discriminator, and as is standard, we are going to start with the points that are 5 millimeters apart, and I'm going to ask my client to close his eyes. Are your eyes closed? Yes? Okay. And we are going to start by testing the fingers where the receptors are the densest in the distal phalanx. And we are going to randomly test a couple points on the fingers 10 times. And we are going to doing, like I said, the 5 millimeters apart and on both the radial and ulnar side of the fingers. And you're going to apply just enough pressure so that the skin blanches like this and lift off. That might have been a little hard, but the client will report to me with feeling 1 or 2 points, and if they're not sure, they will say, I don't know. So are you ready to begin?
Yes.
Okay.
2, 1, 2, 2,
Oh,
2, 2, 2, 1, 2, 2.
and if the client would report 7 out of 10 applications correctly for the 1 to 5 millimeters, as is what we were starting with, then they would be in normal static 2-point discrimination. As you just heard, the client must respond accurately to 7 out of 10 of the applications when the tool is set to one of the following numbers
of millimeters apart to receive a score in that category. From 1 to 5 millimeters, there's normal static 2-point discrimination. 6 to 10 is fair. 11 to 15 is poor. And if only 1 point is perceived, then only their protective sensation is intact. And that is how you would score this assessment. There's no score sheet. There's just these few norms that I was able to find in Pedretti. When administering the moving 2-point discrimination test, we will use one of the 2 devices that I mentioned before. We will test only the tip of every digit, as that's where the receptors are the densest, just like the static test. The client will again have their eyes closed, and we will now begin with a distance of 8 millimeters apart. We'll randomly select a couple of points and, moving proximally to distally, run along the distal phalanx parallel to the longitudinal axis of the finger. We just want to apply enough pressure so that the client can feel the stimulus, and if the client responds correctly, decrease the distance until you find the smallest distance that the client can perceive correctly, and they will report back to you.
So now I will be administering the moving 2-point discrimination test, and this time I will be using the esthesiometer, and we are doing the same thing as in we're testing the tips of the distal phalanx, and the client will have their eyes closed again, but this time the tool will be set to start at 8 millimeters, and we will be moving proximal to distal parallel to the longitudinal line of the phalanx, and also if they respond correctly, then we will decrease the distance until we find the smallest distance that the client can perceive correctly. And again, he will report a 1, 2, or I'm not sure, or I don't know, after each application. So client, are you ready?
Yes.
Okay.
2.
And then we would adjust by centimeter.
1.
And we would adjust.
2.
And you would keep doing this until you reach 10. And then the criteria is, if the client responds correctly 7 out of 10 of the applications, then they would qualify for either perceiving 2 to 4 millimeters of stimulus, which is normal from ages 4 to 60. But if they're above 60 years old, then 4 to 6 millimeters is the normal perception distance when you are testing 2-point discrimination.
Norms for this test, as I just discussed, are a little bit different than the static test. The client will have to respond correctly to 7 out of the 10 applications, just like the static test. But if they're able to report back within 2 to 4 millimeters, 7 out of 10 correct, then this is normal for ages 4 to 60 and 4 to 6 for 60 and older. And any biases regarding these tests would be examiner experience. I read that the more experienced the examiner, the more accurate the test is. There's also controversy over how hard people press the tool into the skin, as this can skew the test results. I've read different numbers of trials that are needed to perform, and if the testing site is administered at another place in the fingers than what it was intended for.